So, Dr. Sandberg-Lewis, welcome to the Health Path podcast, and thank you for sparing some time to come and speak with me.
My pleasure.
So, we have a really interesting topic, I think, to dive into today, which is, if I'm going to get this right, gastrogynecology is the term that we use. So before we dive into the topic, are you happy, Dr. Sandberg-Lewis, just to share a little bit around, I guess, who you are and your background for anyone who's not familiar with you yet?
Yes, I am a professor at the National University of Natural Medicine in Portland, Oregon, USA. And I have been a practicing naturopathic physician in Oregon for the last 22 years, in the Northwest of the United States for 43 years. So most everybody who's gone to National University of Natural Medicine knows me because I've been their teacher for the last more like 30 years because I taught part-time before that. And I practiced, I had a general practice in small towns and also in Portland, a big town, for about 19 years, treating whatever came in. And that, I think, was a really good background for becoming a specialist in naturopathic medicine, because that way I knew about a little bit, a working knowledge about all the different systems of the body. I think it would be a mistake to become a specialist in natural medicine and just really know one system. That doesn't work for a holistic approach. And so about 20 to 24 years ago, I decided I really like gastroenterology, and I was teaching it, and I really wanted to just focus totally on that. So that's what I've done. But again, as a naturopathic approach within the body holistically, I don't separate it from everything else, which is why several years ago I did a lecture, a PowerPoint presentation at a seminar called the intersections among the GI tract, the cardiovascular system, and the kidneys. And the focus of that was for me to prove to myself that it didn't all start in the gut. And it turns out it proved to me even stronger, it all begins in the gut. And now I've turned my attention, because I keep getting pulled in this direction, to the relationship between the pelvic organs and the abdominal organs, because they're really all mixed together in a way, with a little thin sheet of peritoneum between them. And so I'm doing a little focus on gastrogynecology.
Brilliant. So within that sort of field, obviously there's the gut microbiome side of things and the digestive system. What are some of the other conditions that sort of fall within this category then?
Condition that especially amplify the relationship of these two groups, these two systems?
Yeah.
Well, I think any time you have a perforation and a loss of fluids, whether it's bleeding or other ovarian fluids, that, for instance, during ovulation, this fascinating thing happens where there's a very direct connection that gets made between the GI tract and the reproductive tract in the female, is that the ovum matures on the ovary, within the ovary, gets bigger and bigger, and it starts to look like a giant, we call it a bullous, which is a large vesicle, a large blister. And then it explodes, and the egg is hurled along with ovarian fluid, follicular fluid, into the peritoneal sac. And then right it just gets like a somebody shot out of a cannon. And then the fimbriae of the fallopian tube waft it in to the fallopian tube, where if there's going to be a sperm for fertilization, it will be fertilized usually. That's the normal way. And then continue to travel down into the uterus and get implanted. So this is a mixing where you actually have this, shot of an egg into the abdominal cavity, and then if you're lucky, most of the time, the fimbriae will guide it back into the reproductive tract. Sometimes that doesn't happen, and you end up with a ectopic pregnancy, which is a great way to get adhesions between all kinds of tissues, including small and large intestine, and start a process that may lead to chronic GI problems for the rest of that woman's life.
Wow. Okay.
So that's kind of to me, that's an emblematic example. I mean, other things, ovarian cysts, which are almost a physiologic event as well. They're sort of like that cannon getting ready to fire, and then it never fires. Or it does fire, but the sac that it came out of, the follicle sac, never fully goes away. Normally that degenerates and it becomes what's called the corpus luteum, meaning a yellow body. And the yellow body is where you make progesterone for the, after ovulation, because this is ovulation, the egg leaving. And sometimes that doesn't happen, and either the corpus luteum or the follicle remains and doesn't degenerate over time, and you end up with an ovarian cyst. And ovarian cysts, if they rupture after a period of time, can do the same thing that ovulation does, the same thing that an ectopic pregnancy can do, which is to bleed into the peritoneal sac and lead to adhesions, which can cause all kinds of chronic IBS type problems.
Okay, so that's interesting because I was diving just very quickly into some of the research in preparation for today, and I think there was a systematic review that came out recently looking at this sort of interconnection, and the statistic the authors came up with was, I think, a 2 to 3-fold increase in patients with endometriosis having IBS, for example. So just sort of exploring sort of the interconnection between these two things. So what you're saying is, I guess, adhesions are one of those actual mechanisms that can start to explain this.
I think it's probably the most plausible mechanism, but I'm sure there are others. And one study that I looked at said a 3.5-fold increase
Wow.
in IBS in endometriosis sufferers. So yeah.
Yeah, that's quite remarkable, really. And are there any other even theorized mechanisms that start to explain the interconnection and the frequency?
Well, just a fascinating connection that doesn't have to do so much with pathology or IBS, but just there's an article, I think it came out in 2008, that looked at the fact that peritoneal fluid, which is just above these in that layer between the visceral and parietal pleura, which overlies the whole reproductive tract in women. The fluid in the peritoneal sac between the two layers has almost every steroid hormone in it. It's just rich with so many different types of hormones and cytokines and different transmitters of different types. And they were theorizing, and they had pretty good proof, that when the follicle erupts at ovulation, that follicular fluid, and as you know, generally the ovaries alternate months ovulating. They don't both ovulate at the same time normally. So let's say the left ovary, that follicle, ruptures and you have ovulation. The follicular fluid from inside that egg follicle um, space is added to the peritoneal fluid. And then, according to their research, the peritoneal fluid with all of its other hormones and the hormones that came out of there, the estrogen, that eventually makes its way past the right ovary, and that's how the ovaries communicate.
Huh.
It's as if the right ovary gets the message, gets the text, and it says, "Oh, my sister ovulated this month. I guess next month's my turn." And so that's a really interesting idea. But that was the text of their whole article and their research. So I think in many ways, I mean, there's lots of crosstalk going on between the GI tract, the central nervous system, the enteric nervous system, and also every other system in the abdomen and probably every other part of the body.
Yeah, and I think in one of the papers I saw, just the bog standard idea of low grade inflammation being involved in all of these different conditions. So we talk about low grade inflammation in IBS and endometriosis. So there's kind of this immune, as you were saying, I guess, with some of those cytokines and immune mediators that are being released.
Yeah, and I think this all makes sense too in terms of what's the purpose of inflammation and what is it? And when you really, I've thought about inflammation way too much, probably because I taught basic pathology for 17 years, which was really fun. I don't do it anymore, but it was fun. Inflammation in part is the body's response to wall off an area that's considered foreign material, so that this inflammatory process with white blood cells, antibodies, will contain that irritation or infection sometimes, and keep it localized. Swelling, redness, heat, and pain are the cardinal signs of inflammation. And so just creating kind of almost like a pseudo clot in that area, thickening the fluids, bringing in more blood, bring in more white blood cells and other substances, and kind of walling it off so it doesn't become systemic. And systemic inflammation, we see that all the time in modern chronic diseases, and it's not pretty. So when inflammation works well on the local level, on the tissue level, it helps contain and resolve that irritation, that foreign seen, whatever it is that's seen as foreign, takes care of it and keeps it from becoming systemic. So in tissues that have communication with the outside world, such as the vagina and the cervix, I mean, it's not really the outside world, but there is an opening there, or the urethra, or the GI tract, which is really the outside world, because you're putting things from the outside world right into there. Water that might be contaminated, or food that's got all kinds of organisms on it, and toxins and other things at times. So that low-grade inflammation is a normal process in these organs that have communication with the outside world to respond to it and to deal with it before it perhaps becomes systemic. And I think it's extremely important. But then when you introduce it into an area that doesn't normally have much communication with the outside world, say by extruding some endometrial tissue from the lining of the uterus into the peritoneum or some other organ, the bladder or the uterine tube, that's a whole different kind of process of low-grade inflammation, sometimes not so low-grade.
Mm. Yeah, I was going to say, so it's almost like when we're talking about low-grade inflammation in some of these papers, I guess we're still talking about levels that are exceeding what would be normal, so to speak.
Yeah, that would be ideal in a system that was functioning with homo. I just lost a word. Anyway, yeah, that would be
Yeah,
keeping itself in balance.
sure. Okay. And I guess from a sort of a digestive microbiome perspective, how does that then fit in? So I think it was off air when you sort of mentioned, obviously, that the gastro element of gastrogynecology is the more important part. So trying to maybe bring this to a slightly more clinical or certainly practical perspective for people, what would be some of the things that are worth discussing in regards to overall and sort of general gut health and what might be going on from a gut perspective that could then contribute or exacerbate these sorts of conditions like endometriosis, etc.?
Well, my apologies to gynecologists. I think all the systems are important. I just keep running into the GI tract being especially important, at least co-important. So your question is, what's an example of the GI tract, maybe its function being a little off, and that leading to more problems with gynecological disorders?
Yeah.
I think the classic one is, what we talked about just before was sort of proximity of those organs. Even, a uterine, the most common neoplasm in women is uterine fibroid, benign neoplasm. And uterine said to affect maybe 25% of women. The uterine fibroid, just because of its size, any benign growth, because of its size causing pressure as it enlarges against surrounding organs, could lead to constipation, especially if it's posterior, on the posterior side, and it's bulky, and it's pushing against that pouch, the pouch of Douglas, which is between the uterus and the rectum. It's right there. So, there's just a benign gynecological condition that could lead to problems with the GI tract, or because the uterus sits on top of the bladder, it could cause frequent urination or urinary irritation. So that's proximity. But then there's also hormonal connections. And so through the GI microbiome, we have bacteria, especially Clostridium, I believe, that have the job of creating beta-glucuronidase. And that enzyme, which especially if there's an overgrowth of that form of bacteria in the large intestine, you will have more beta-glucuronidase. And what beta-glucuronidase can do is it can convert estrogen that has been made more water soluble, so it could be secreted in the bile and removed from the body and turn it off. And it's made a less active when it's conjugated. The liver does that, takes it out of the blood, secretes it into the bile. It works its way down the 18 to 20 feet of small intestine, enters the large intestine. It's about ready to come out into the toilet bowl. Goodbye estrogen. And if you have enough of these bacteria that make beta-glucuronidase, they will deconjugate it just before it leaves and reactivate it. It gets reabsorbed into the blood and it circulates again. And we know that this kind of estrogen dominance, excessive estrogen compared to progesterone and other sex hormones, is a common underlying theme in many of the chronic gynecological problems like breast cysts, fibrocystic breast, even breast cancer, certain breast cancers, certainly PMS, possibly PCOS, but that's a whole different ball of wax, and perhaps uterine fibroids and other uterine problems like uterine and endometrial hyperplasia, which can be a precursor to endometrial cancer. So this estrogen dominance really, we think, often begins in the GI tract with the microflora producing more beta-glucuronidase.
Yeah, that's very interesting. And I think from a beta-glucuronidase perspective, you mentioned Clostridium there. I'm not sure if it's like generally just those gram-negative bacteria that sort of contribute to that overall beta-glucuronidase load as well. But it's certainly a common marker that gets discussed when we're talking about estrogen dominance.
Yeah, and there's a lot of talk about how more vegetarian and vegan diets tend to promote less of that beta-glucuronidase producing flora than heavier meat-eating keto diets. Every miracle diet has its drawbacks.
And is there anything else that would, on that point, that is worth considering? So if someone did have elevated beta-glucuronidase, potentially moving towards a slightly more plant-based diet might be one consideration. Are there any other kind of go-to interventions that people could consider?
Certainly, yeah. I mean, the biggest one that comes to mind is calcium D-glucarate, which is thought to help disarm that enzyme and reverse that process. And then, of course, if there is in fact too much estrogen or the various E1, 2, and 3, E1 and 2 are the more growth promoting types of estrogen, you can work with, again, with methylation pathways, which is part of the way estrogen gets detoxified. You can work with the 4-hydroxy and the 2-hydroxy pathways to try to get a better, safer conversion that doesn't go through the quinolone pathway. And you can use things like iodine extracts, DIM, those kinds of things that are used to strengthen those safer metabolism pathways for estrogen.
And I guess talking about sort of methylation there, then we're talking about sort of B vitamin status and cruciferous vegetables and things like this to consider as well.
Yeah, definitely. Cruciferous fits right in there. And yeah, the B6, B12, and folate.
Perfect. Okay. And now I guess that makes sense. But when thinking around gut health and how it can contribute or maybe exacerbate some of these things, and if I think, thinking of endometriosis as a estrogen dominant inflammatory condition, anything that is increasing that inflammation therefore needs to be a factor. And then gut health comes into its own from that perspective, I guess. Is it worth touching on the adhesion a little bit more? You've obviously come onto my my personal podcast before where we spoke about SIBO and some of the underlying causes of SIBO. So from memory, we probably touched on this a little bit last time. But would you be happy just to maybe expand on this concept of how adhesions can then impact on digestive health?
Yeah, I'm happy to nerd out on almost any topic like this. So adhesions, of course, are a type of fibrous tissue that is part of inflammation. It's part of the healing process.
Okay.
And, there's primary and secondary intention. primary and second intention, as they're called in pathology. And primary intention is regeneration of tissue after it's been damaged or lost. Recreating tissue exactly, or with the same materials that it initially was made. Sometimes the gap, say there's a big gash, and the gap between the two layers is too big for epithelial cells to cross over the divide, and you have to have second intention for the healing process, which involves fibrous tissue, scar tissue. And you try to prevent that. That's why we sew incisions together, or we don't just leave them gaping open, because they're not going to heal without a lot of scarring. And so it's a similar process when in the gut you have, let's say with endometriosis, you have a monthly bleed into the peritoneal sac, or into the bladder, or into whatever organ, the fallopian tube, whatever tissue this, what's called an endometrial rest, is located. This bit of endometrial tissue. And it's responsive to the same hormonal signals as those same tissues within the uterus. So it bleeds each month. It enlarges, develops more hormonal producing cells, and then it bleeds. And when you bleed into tissues that aren't used to blood, they're used to serous fluid, which is very comforting and is bathed in that. But all of a sudden when there's blood's very irritating to the peritoneal tissues and other tissues where you might find this, say within the ovary. I believe the ovary and the tubes, those are the most common locations for endometrial rests. And so when you have monthly bleeding, or every other month bleeding into those tissues, maybe monthly, then you're going to have some scar tissue forming, some adhesions. And adhesions, by definition, are attaching the serosal layers, the outer layers of tissue, such as small intestine, or the outer layer, the serosal layer of the large intestine, say to the small intestine, or to the bladder, or to the uterus, or to whatever organ there is in the area, or even to the pelvic bone sometimes. These adhesions can be anywhere. And so you end up with this, if it is happening every month, you end up with this matting, complex, thickening layer of adhesion that's connecting things that aren't supposed to be connected. And you end up with either something like a donut around the outside, say, of, let's talk about small intestine, a donut around the outside of the small intestine, a thickening that is narrowing the internal lumen of it, and which slows things down, leads to partial obstruction. And we know that adhesions are a very common cause of small intestine obstruction, whether partial or complete. And when it's complete, it becomes a surgical emergency or a hospital emergency. Or instead of that, maybe just creating a hairpin turn or kind of a kink in this intestine, which also can lead to partial or complete obstruction. And partial obstruction, long term, we usually call SIBO. Anything that slows down that cleansing wave of the small intestine can lead to overgrowth of bacteria or archaea. And it's a partial obstruction or a slowing down of that cleansing wave because of a kink or a hairpin turn. That gives the bacteria a nice place to just sit there and multiply. If bacteria sit, I don't know if they sit. They probably just lay there, but they don't bend. So that's my long-winded explanation of adhesions. and how they can lead to basically, SIBO equals IBS. 80,
Yeah.
maybe 84% of cases in the studies that show the largest connection there. 84%, up to 84% of IBS is due to bacterial overgrowth.
Mm. Brilliant. Okay. So we've spoken about various connections here. We've spoken about sort of the proximity of these organs. We've spoken about beta-glucuronidase and the general, I guess, makeup of the microbiome. We touched on the idea of methylation processes and pathways being important as a way to metabolize estrogen. You've given some supplement options like calcium D-glucarate and DIM. We've spoken about adhesions and the role that they can play. Are there any other factors that are worth highlighting along this line?
You must have been a really good student because you pay attention. You can give it all back as an outline. Other connections that I want to bring up between the GI tract and the gynecologic tract.
Mm.
Well, I thought about the fact that, well, let me ask you, what do you think, where do you think the microflora of the, let's say, the vagina, where does it come from? Where does it start?
That's a good question. I have no idea.
Okay, well, this is fascinating to me. So think of this. We've got billions of bacteria per gram in the large intestine that we're supposed to, right? And those include lactic acid bacteria and many other forms of bacteria and yeast and other organisms. And they're all happily living there in a healthy state. And when a woman passes gas, that air, or has a bowel movement, that material shares bacteria, not just stool. I mean, because it's got billions of bacteria per gram, or the gas itself may have bacteria and yeast, kind of being wafted out into the peritoneal area. And certainly, women are generally taught by their moms not to wipe after a bowel movement from back to front, but just the other direction only, once, if they're using toilet paper. And that's because you don't want to share too much of that GI microbiome with your urethra, which often doesn't handle it very well, and the urethra is short in women compared to men. And so bladder infections, cystitis, can be brought on that way. But of course, the vagina is in between the urethra and the anus. So you can also get vaginosis, vaginal infections, from your digestive tract. And you can get normal flora, lactobacillus, from your digestive tract. It's just a matter of whether it's overwhelmed or not. There's actually even a type of vaginitis called cytolytic vaginitis that you may have heard of that's caused by excessive lactobacillus. In the vagina, the lactobacillus generally has been called Dorderland's bacillus in the past. Dorderland's. They gave it somebody's name. Probably a man. I'm not sure. But anyway, fallopian was a man too, by the way. But so what I'm saying here is that the resident healthy normal flora, predominant flora, which is a lactobacillus in the vagina, comes from the digestive tract. It's kind of a cross-contamination or a sharing. And normally that's a healthy thing unless other kinds of bacteria are also moving through. And if a child is born by vaginal birth, they get lactobacillus. They're bathed in lactobacillus on the way out, which they don't get when they're born by cesarean section, which is why every new patient on their new patient form, I ask, were you born by cesarean or vaginal? Were you breastfed? And if so, how long? Were you in the neonatal intensive care unit or not? Those are important questions that can affect your health on all levels for the rest of your life. Not that you have to write a nasty letter to your mom because she had a C-section and didn't breastfeed, but it really does carry through life to some degree or other, depending on the case. So there's another connection, this proximity, and it is the sharing of resident flora.
Amazing.
Including yeast.
Okay. And am I right in saying that from a sort of a vaginal microbiome perspective, it's kind of the opposite to the GI microbiome in the sense that diversity is not really what we're looking for? The vaginal microbiome is more dominance of lactobacilli. Is that right?
Well, they talk a lot about Lactobacillus reuteri as a major factor there. I have to tell you, I've just started. I'm a novice about this. I'm interested in these connections. You know, I've thought about them over the years, but I really haven't studied the vaginal flora the way I've studied flora in other areas. And I'm not a microbiologist, so I don't consider myself anything like an expert on that part of it.
Sure.
But that'll be one of the next things I look at.
Yeah.
Right. I've actually been studying the oral microbiome more in the last 6 to 9 months.
Okay.
Looking into that.
Brilliant. Yeah, that seems to be the new thing. That's for sure. So with all of that in mind, are there any other things from sort of an intervention or lifestyle perspective that would be helpful to talk about? We've kind of mentioned from a dietary perspective that maybe moving more towards a plant-based diet, certainly with the idea of beta-glucuronidase, is important. But is there anything more actionable that is worth just highlighting at this point in time? Or using examples as ways to maybe to go down that path?
Yeah, I would also just, as a corollary to what you just said, I find most of my patients who have chronic digestive problems and IBS, they don't do very well with plant-based diets. In fact, some of them they just don't tolerate initially any raw vegetables, and even sometimes cooked vegetables are very difficult, and fruits. So I wouldn't say that would be my prescription, although for someone who doesn't tolerate those very well, moving toward using more cruciferous vegetables and iodine-containing foods, which could be fish, the right kinds of clean fish, or sea vegetables, if those are tolerated. Okay. Might be another way to help push those reactions toward a better place. Other recommendations in general for gastrogynecologic health. Well, I'll tell you, there's this perspective in naturopathic medicine, and maybe it just comes from more old school ideas, this idea of pelvic congestion as being one of the underlying factors in a lot of gynecologic problems. And this is the idea that blood flow through the pelvis, lymphatic drainage through the pelvis, these things can become stagnant. Just like old school, we talk about liver congestion as well, where the liver being a filter for for the blood becomes a poor filter and gets congested. The same thing can happen in the pelvis. So think of this, male or female, but especially with female, if you're in a profession where you sit, or not even a profession, just a lifestyle where you sit 8 hours a day, that could really promote pelvic congestion. First of all, because you're in this 90-degree or so flexion at the hip, which isn't ideal. And if you're not walking and getting that bilateral cross crawl activity to pump especially your lymphatic fluid from your lower extremities back into the general circulation, which, it enters the general circulation around the shoulders. If you're not getting much of that, you get a lot of lymphatic congestion, and that can pool in the pelvis, and that can be an underlying destabilizing factor for all kinds of problems, including estrogen dominance. All that estrogen that's being produced there in the pelvis, not really going too far, maybe just spending a lot of time in those organs instead of flowing systemically as much as it should. So I would say that's another important thing, is bilateral cross-crawl activity, walking, cross-country skiing, swimming, whatever it is that moves the legs and the arms. And an excellent exercise, which was presented to me, I forget where I learned this, I think from one of our student doctors about 15 or so years ago, hula hooping. So dance that involves the pelvis, any exercise that involves the pelvis. And hula hooping is a great one because it creates this rotational gyration that really can help move fluids. But really anything about moving the pelvis can be really, really important. So I wouldn't want to leave that out as a really important factor. We used to use, I wonder if some NDs still do this. I haven't seen it in a while, but I think they do. We used to use something called a vaginal depletion pack. And what it was, we would make it in the clinic when I was in the clinic in the 1970s as a student. If a woman came in and she had any kind of uterine issue, any kind of pelvic congestion, we would take pure lamb's wool that we bought in bulk, and we would open a layer of it, and we would have this mixture that we had put together ahead of time. We run out, we make some more. It had anhydrous magnesium sulfate, and we would mix that with glycerin, golden seal. I think we used a powder, golden seal, bitter orange. That was a liquid. And I think there was also something called VM120, which is still, I found it on the internet a couple of months ago. And it's actually an aluminum silicate, I believe. So the anhydrous magnesium sulfate and the aluminum sulfate tend to draw things out, just like clay has a lot of aluminum, and that's a drawing effect. We didn't use clay in there. And then we had the golden seal with all of its amazing properties for healing tissue and killing certain organisms. And then the bitter orange, which also is an excellent antimicrobial and anti-yeast action. And we would close that all up, tie it up with some clean floss, and make this little tampon kind of thing, and then put in a speculum, push it in, sort of like loading a cannon. We're going back to the cannon again. with a applicator, we would put it in right up against the cervix and take the speculum out. So there would be this this nice little bolus of herbs and minerals right up against the cervix, and that was the vaginal depletion pack. And it would draw fluids and toxicity and
Wow.
bacteria and yeast out of, and kill those things, out of the uterus and surrounding tissues. And we would leave it in for, I think we would leave it in for 4 days, and the woman would then pull it out with the string. And we put another one in the next week, and we would do that for a period of time to help with that chronic pelvic congestion, along with exercise and diet and other treatments. So there's a really, really ancient, oldie moldy naturopathic treatment that I learned in school. We just did that for so many gynecological conditions and had really good results.
Wow. That's super interesting. Okay.
So, that together with hula hooping or some other core exercise, it's a great idea.
Yeah, it kind of reminds me of some of the studies that have looked at sort of yoga and IBS. And often those yoga flows are incorporating quite a lot of rotational movements around sort of the hips, pelvis, torso, I guess. So yeah, makes complete sense.
I would assume that things like belly dancing and African dancing, those traditional dances for women, are probably different than the ones for men because of that need to prevent pelvic congestion.
Brilliant. I actually have a colleague, well, an associate. I'm going to forget her name at the moment, but I know that she does some quite specific pelvic and hip opening type exercise classes. Basically, she's got some online courses that I'll have to put into maybe the show notes for today's podcast, because I think it is a key piece of what we're doing. That's brilliant. Dr. Sandberg-Lewis.
I just would say one last thing, is that pelvic floor work, physical therapy and massage that involves the pelvic floor can be very important, not just for problems like interstitial cystitis and pelvic pain syndromes, but also for rectal issues like rectal dyssynergia, where women have constipation due to problems in the coordination of the internal and external sphincters of the rectum. And that can be essential to normalize that process. Because remember, constipation could be slow transit, but it also can be a problem at the garage door. If you don't open the door properly, you can't get your car out.
Right.
And you can't get the stool out of the rectum if the external sphincter doesn't relax when you bear down. And that's something that some men and women have to have worked on with pelvic floor exercises and visceral work.
Fascinating. Okay. Brilliant. Dr. Sandberg-Lewis, thank you very much for coming and chatting to me today. I think it's a really important topic. I definitely can look back over the years and think of some of my clients whereby there was a clear connection between what was going on from a hormonal and monthly cycle perspective with their digestive symptoms. And some of those clients went on after us doing some sort of gut work to understand actually that they had an, at the time, undiagnosed condition, whether it was endometriosis or PCOS. So I think it's a really important topic to get out there ultimately. So thank you for sharing your insights and experience.
Yes, and I would be really interested in anyone who has pondered about this or has more information about the connection of these two systems, if they wanted to email me and share that. I've just started really putting some things together after all these years. So
perfect.
That'd be great.
What's the best way for people to reach out to you if they do want to share or collaborate, etc.?
So my private practice is Hive Mind Medicine in Portland, Oregon. And if you write to info@hivemindmedicine.org, I will get that. There's a short version too, info@ hmmpdx.com. PDX for Portland, and
Okay.
HMM for Hive Mind Medicine. One's org and one's com.
Okay.
So, yeah, I would welcome that.
Perfect. And we'll put those into the show notes for you as well, so people will be able to access those easily. Excellent. I'm going to go away and ponder on some of these points a little bit more. So, Dr. Sandberg-Lewis, thank you very much, and hopefully we'll connect again soon.
Yeah, it's been a pleasure talking with you.